is to really just describe some of the current topics that we cover in this course, and engage on a comparison between, what you all are doing in clinical practice, what things you're seeing as kind of the highlights of what we're teaching, and just have a conversation about what ways current educational standards are meeting those goals and in what ways you might need to make some shifts. Just a disclaimer, the slide deck that I've put together is not comprehensive of everything that I teach in the Physical Exam 1 and 2 content courses, but it's really meant to start a conversation and revisit some of the foundational concepts that we cover. So a little bit of background that I felt was important to share before getting into this coursework. So as Megan said, I'm a lifelong learner, and my husband knows that if somebody paid me to go to school for the rest of my life, I would sign up yesterday. But I'm pretty sure I'm done with school. I did my undergrad at Rice University. I was a history pre-med major that switched to secondary education my junior year. Decided to get back into healthcare and earn my master's in athletic training at University of North Carolina at Greensboro. Through athletic training, as many of us have, stumbled into orthotics and prosthetics and figured out it was the coolest profession out there. So I got my certificate in orthotics from the Newington Certificate Program, which is now University of Hartford's program, and my certificate in prosthetics from NUPOC. Once I was working at Baylor, knew I wanted to get into, assessing program outcomes, doing educational research, and decided to get my PhD in higher education at University of Houston. I share this because at one point in time, I was a certified athletic trainer. I've not kept up that certification. And I am currently a certified prosthetist orthotist, but a lot of what I teach in this course really came from my background and training as an athletic trainer. And I've tried to take a lot of that work and apply it to prosthetics and orthotics. I had great education in my orthotic and prosthetic certificate programs, but there really wasn't a massive emphasis on this course content. So just wanted to share that with the group as kind of a little bit of kind of a personal experience today. So one thing that I think is important is describing and sharing with you all the educational standards that we meet through our coursework. And as a clinician or an alumni preceptor, you will probably don't look at the KHAT Masters standards and kind of know them like the back of your hand. That's probably a good thing. However, I do think it can help us bridge this idea of an academic practice gap with becoming more familiar with, the standards that we have to meet as an educational program and how that relates to what you're seeing with a resident or a new clinician. So this coursework that I teach, I think really covers these two broad competency areas that are in the current NCOAT Masters standards. You can see here A7 and A8 in relation to, the fundamental science of human function. And here we're really pulling out the assessment and formulation part of that practice framework. But that could also move into implementation and follow-up. And then really where I try and focus the content in physical exam is how everything that we do from an assessment standpoint relates to our clinical decisions. Our physical exam coursework here at Baylor also gets into selection of some outcome measures in the second part of that course. And then if you really wanted to get into the details, here are some more of the nitty-gritty stuff that are in our master's standards that are assigned to the physical exam coursework in our program. So every program goes through a curriculum mapping exercise where they look at all of their courses and say, who's responsible for which content? We recently redid this exercise ahead of our upcoming site visit for accreditation. And these are the areas where at the end of the two physical exam courses, I need to make sure I've documented that students have demonstrated skills within these areas. All right, these are our two main text references for the physical exam coursework. So Daniels and Worthington muscle testing, and then Berryman, Reese, and Bandy's joint range of motion and muscle length testing textbooks. These are the references that I have in my Kindle. These may be actually one edition old, but this is what our students use as their primary references for a physical exam. I also pull in portions of other textbooks, specifically related to orthopedic special testing. The Hoppenfeld examination of the spine and extremities book, for example, is another one that I reference frequently. But this is kind of the nuts and bolts. And I always try and tell students, right, that when we're teaching them this course content, we're teaching them in a way where they're using references that other healthcare professionals are also using. So they're learning these skills and procedures in a way that a physical therapist or an occupational therapist, an athletic trainer might be learning them. And that really helps when it comes to interprofessional communication and kind of demonstration of our expertise as prosthetists, orthotists, to be speaking the same language here, which is really important. All right, so before I keep going, I have a few audience polls that I will get rolling. Oops, hang on one second. My cursor, there we go. Okay, polls. All right, can I get a thumbs up that you guys can see? Okay, excellent. First question was, I was prepared to conduct physical exam of a patient requiring orthotic prosthetic intervention when I started residency. I'd love to hear your agreement with the statement. Yeah, you can keep going through the poll questions. So far, it looks like most of us in the room felt they were prepared for physical exam starting residency. Second question is about whether you believe current residents are prepared to conduct physical exam of a patient requiring orthotic prosthetic intervention when they started residency. Majority agreement, but a few folks who are feeling a bit neutral about that item. Third question is, there are accepted standards of practice for examination practices in orthotics and prosthetics. Notice here, I didn't necessarily write written standards of practice, but this is more the idea of we have an idea in our head about what should be happening for certain types of patient populations or certain types of device intervention. So a little bit more variance in that answer. Can you all see the results? You cannot. Okay, hang on. I'm not sure if I hit in poll, you all see it. So I'm going to read the last one and then I'll hit share. The last one was physical exam findings are important components of orthotic and prosthetic decision making. And 79% of you all said strongly agree here. So let's see what happens when I in poll. Oh, here we go. It's been a while since I've done a Zoom poll. Share results. Okay, here we go. You guys can now see. So frequency of responses for our first question. For a second question about resident preparedness. For a third question about standards of practice. And our fourth question about physical exam findings. And I'll share with you all, I kind of wrote this question because some of the things we hear from students, especially coming off of shadowing hours, and sometimes we hear it from residents, is like, I don't really see my mentors or the clinician I'm shadowing doing this. They're really using observational gait analysis. And we have a great conversation when that happens about using observational gait analysis to inform your exam, and then have a realistic conversation about the time crunch that sometimes happens in clinic and talk about how we can filter things down to what we need from an exam standpoint. All right, thank you guys for that. So I'm going to dig into, I think, step by step, some of the foundational things we teach the students. And again, I'd love to feel free to put comments or considerations in the chat. So in this course, we set the groundwork by talking about patient interaction. One of the first things that our students do in the program is they just do a meet and greet with our patient models. So they don't do any physical exam, but they do start the process of taking a patient history. And we focus a lot on just what that interaction should look like. In school, it can be difficult to give them a whole lot of preparation content like they would get in clinic in terms of looking at chart notes, the prescription, any medical record. But we do try to give them some information about their patient models to start to model that process before they get out to clinic. We talk about how you go into a patient room, knocking on the door, greeting the patient by name, greeting anyone else who is in the exam room and verifying who those folks are, shaking the patient's hand if it's appropriate, and positioning yourself to have eye-level contact and communication with the patient if that's possible. We also talk about where we sit in the room with that patient, try and make sure there's not any physical barrier between us and the patient before we start to do that process of obtaining a patient history. And then we also talk about some of the things that we start to need to kind of start to assess the scene as a clinician. What are some of the things that you're looking for? Aware of the patient's status in regard to alertness, ambulation, cognition, in a way, just starting to read the room. We may not make definitive findings, but we're really trying to survey the scene as we begin this examination process. The other piece I always get to harp on every year with students is this is not the time where you are putting on your exam gloves. You are sitting here and establishing rapport with your patient and starting a communication. And before you move into that physical exam portion, we talk about educating the patient on what's going to happen next, getting their permission to move forward with that part of the encounter, and then moving into PPE. So here are some of the generalities we talk about. And, I think this is probably all not new to anyone in the room. But we start to differentiate between what might an experience taking a patient history look like if I'm dealing with an acute care situation or someone who has a chronic condition. Really to try and start talking about the nuance between different types of encounters and different types of orthotic and prosthetic intervention and needs. So focusing on starting that conversation with chief complaint or an understanding of why this referral to orthotics and prosthetics took place, getting information about the date of injury or diagnosis. Pain is a huge one for most of us in most encounters. And then we dig in deeper there. What's the type? What's the location? Can they qualify or quantify that pain? What makes it worse? What makes it better? What's the patient's job or hobbies? What's their history with orthotic and prosthetic intervention? Surgical history that might relate to orthotic and prosthetic intervention, fall history, any additional medical conditions or comorbidities, any other active members of the care team. What does this rehabilitative process look like for that patient right now to understand a full picture? Any skin allergies ahead of any type of contact with the patient or consideration for material choices. And last, but certainly not least, right, a conversation with the patient about their goals. And when the students start this process, right, they typically generate a laundry list of questions, and they could be there for an hour having this conversation. Over the course of the 2 physical exam courses, and in addition to the content that they're getting from the course directors who are teaching orthotic and prosthetic coursework, they're learning to narrow these things down based upon the context and the situation, which I think is really important. But this piece, I feel like, is also an important skill that continues to get developed during the residency portion of the program. All right, so one of the acronyms I learned as an athletic trainer was HOPS, H-O-P-S. So it stands for History, Observation, Palpation, Special Tests. And we really try and teach the students to follow this framework. It also mirrors what you might see in a SOAP note, right? So we're in a sense living out the SOAP note process in our evaluation process. We talk about how over time, 3, 5 years into practice, they're going to start developing skills where they can kind of jump back and forth between procedures, maintaining small talk and getting information that they need to become more efficient. But in reality, for a new resident, that's not where they are going to be. They need to compartmentalize that process to start to develop the muscle memory, in a sense, of what that looks like, to make sure that they're getting everything that they need. So what are they observing, right? We're looking at the things in the room, device condition, any assistive devices being used or being present. Again, that may be a conversation as well. Shoe condition, limb condition is huge, right? Before we start to put our hands on a patient, let's observe the limb that we're working with. Skin integrity, are there any signs of inflammation? And some of this contact overlaps with our pathophysiology course, where they're kind of learning about these processes. And now in exam, we're starting to look for them. Palpating bony prominences, cut end of the bone, any suture lines or adherent scar tissue, trying to get a feel for that soft tissue and what that might be like from a modification standpoint. And then observing as well functional movement. So any upper extremity dexterity, ambulatory status, and moving into observational gait analysis. So I will share with you guys our observational gait analysis content is in our biomechanics coursework, but there's kind of heavy overlap between that and decision-making and physical exam. So one of the things that I try to reiterate with our students, and this is really revisiting this repeatedly over the first year of the program, is your patient history and your observational gait analysis should inform your physical exam. And those three things should match up. So if in the process of your evaluations, one of those three things doesn't align, go back because something was off. Maybe you missed something in the history. Maybe you didn't catch something when you were doing gait analysis. Maybe you thought that was a 4 out of 5 from manual muscle testing, but it really wasn't. So use these things as cues just to check and confirm what you're finding. Okay, range of motion, we start everything with identifying bony landmarks and palpation, but then we quickly move into range of motion in the course. We differentiate between active and passive range of motion, learning to gather information from active range of motion, which is always completed before manual muscle testing occurs. But it's important for the students to pick up information from active range of motion. And one of the biggest things we talk about is, your active range of motion assessment is not how you grade your muscle strength. I think new students are often quick to be like, oh, they could range against gravity. They're a 3 out of 5. Wait, no, that's our starting point. But these two things are really separate. So active range of motion is telling us a lot of things. It's telling us, can the patient follow instructions? Are they able to move that joint? Does give us a preliminary assessment of strength. It does give us an indication that there might be weakness or movement limitations. It could be based on pain, could be based on hypertonicity. And from there, we would move into passive range of motion to further assess that joint in 2 scenarios, which is what we teach them. Scenario number 1 is they observe a deficit in active range of motion. And so now they need to follow up and measure passive range of motion. Scenario number 2 is, in order to make sure that I have appropriate alignment of my orthotic and prosthetic device, if I need passive range of motion measurements at a joint, then I have to take it in this context. So we talk about, if this is a case of lower limb orthotic intervention, AFO versus KAFO, or lower limb prosthetic intervention, considerations for bench alignment in both transtibial and transfemoral. So we create these lists with the students of like must-do items so that they can then make informed decisions in clinical practice. Manual muscle testing has come up a lot, and I think part of this as well is that you see a variety of approaches to this in clinical practice, both from the text that we use with our students and from kind of other review in the literature that I've done. I've chosen to teach them what's called a break test. It's the most reliable approach to manual muscle testing, which for new students is often really confusing to learn anyway. We do use a handheld dynamometer as an exercise for them to start to gauge how much force they're using when they are applying resistance for manual muscle testing. That helps. We shift them around with different partners and we have them give each other feedback on the amount of resistance that they're applying. That helps. All of this is an effort to start to calibrate that force application, which I know you guys as clinicians on the call, at this point, you probably don't even think about like how much force am I actually applying to this limb because you're very used to that. But new students, they have no idea how much to push when we're teaching manual muscle tests. So a break test is helpful for that. And break test is an application of force by the examiner at the end range typically, or whatever position for that joint is strongest. So we talk about for some of our muscles, particularly our biarticular muscles, that strongest position is closer to the mid-range of joint motion. However, for some of our long, thin muscles with long tendinous units, great example of this is our anterior tibialis. That strongest position of that muscle is at end range of dorsiflexion if you're testing dorsiflexion. So we do some exercises for them to feel that difference and try and impart the importance of patient positioning to get this assessment. So some of the other things that you'll see in clinic are what's called a make test. This is a test where the examiner kind of gradually loads the limb with that resistance. They say, oh, I'll give you a count of 3. I'm going to start to increase how much I'm pushing down. Make sure you can resist my force. The challenge there, right, is this kind of ramp up in force application, which can be hard to modulate as the examiner. Even harder to modulate is if you're trying to apply this force throughout the joint range of motion. And you'll find literature that says this is a completely unreliable way to do manual muscle testing. Having to apply resistance consistently through a joint range of motion is just very, very challenging for us as humans. So break test, one position, they instruct the patient to try to prevent, try and resist my movement, try and keep your limb here, try and keep your leg here, try and keep your arm here. I'm going to push down, try not to let me move you. We found to be, and others as well, have found to be the most consistent. The other thing that we use is a 6-point scale for grading manual muscle testing. I fully acknowledge that in chart notes, they're going to see pluses and minuses. We give them references for how to interpret that. That being said, the pluses and minuses offer an additional layer of inconsistency in muscle grading. So I force them to stick with the 6-point scale. They have to make a decision. If they want to note range of motion deficits that they found as part of manual muscle testing, that's perfectly appropriate. But this is the most reliable way to do it. All right, so narrowing it down. This is one of the biggest pieces of feedback that we get from both the residents and preceptors when they start residency, because they're kind of like, well, we learned all this stuff in school. I only have 30 minutes with this patient to do an evaluation, take an impression, get my coding to the front office, start to write my note. I got to move a little bit faster. How do we do that? As I've already mentioned, use your gait analysis where possible to guide manual muscle testing and active range of motion testing. Really, really important. So we work with the students on starting with that OGA process and trying to come up with the differentials of what's causing what they're seeing. Could this be a hamstring contracture? Could this be spasticity in the quadriceps muscles? Start to make that list, write it down, and then use that to inform what they're doing in physical exam. Again, as I've talked about, passive range of motion is not necessary to measure on every single joint every single time. So picking and choosing when we're doing that based on whether we think there's a joint motion limitation or we need that measurement to determine appropriate orthotic or prosthetic alignment. When are we assessing less than grade 3? Well, when we observe that someone is not able to achieve grade 3, which would be range of motion against gravity. And I have a note here, like consider implications for O&P decision-making. I think if you all put us to the test and asked, how would you do something differently if a patient was a grade 0, 1, or 2 for MMT? I think in a lot of cases, we might not do anything different clinically. But it's important for us to be able to differentiate between those grades and have that documentation in our chart notes in the case that the patient's condition changes over time. And then special tests, we work through with the students, kind of guiding those special tests based on the device or the level of orthotic or prosthetic intervention. All right, so what does this look like in reality for our students in the classroom? So at the end of physical exam 1, the students have to perform a comprehensive upper and lower limb active range of motion and manual muscle testing assessment. We give them 12 minutes to do that. Now, I fully recognize that they are at this time in the class, they're working with each other as peers. So, if we're in the IRB context, this is healthy patient normals, as they say, which makes a big difference. But at the beginning of this course, my emphasis with them is very much rote memorization of these procedures so that you don't have to think about how I assess shoulder abduction strength in a patient who's demonstrating that they might have deficits. You can make that decision and your body can move into doing that assessment, which is really important. If you guys are, I think a lot back to a book called Make It Stick, which talks about, how you have to think fast and think slow, and what things you have to really have ingrained in your brain that you don't have to think about in those critical moments when you have to make the decisions. So that's where they start by the end of the first course. And then in the second course, we move into kind of looking at more specifics based on patient presentation, making the decisions when it's their turn to determine what needs to happen in that encounter. All right, an overview of some of the special tests that we teach. I think this is one that could make for a lot of good conversation with clinicians, because some of these things we might be using on a daily basis, and some of these things might only come up a couple times a year, depending on what we're doing. I think one of the other big pieces to consider here is that we want our students to be familiar with a lot of this content, these tests, and these findings, because it's very likely that they are going to see them in a note from a physician or a physical therapist. And so being able to understand what these things mean in a chart note could be helpful. But we definitely teach the students how to assess dermatomes and myotomes in the context of working with a patient who might have an incomplete spinal cord injury, for example. We focus on muscle length tests, predominantly in the lower limb. They do have references in their texts about how they might assess some muscles in the upper limb as well. But we focus on the lower limb. We do talk about sternocleidomastoid in the case of cranial orthotic intervention. We look at ligamentous integrity tests. So stability at the shoulder, the elbow, and the knee is where we focus. So varus and valgus stress test, anterior posterior drawer tests, the sulcus sign for the shoulder complex. It's really where we limit that. From a nerve test standpoint, we're predominantly looking at a few tests for nerve impingement. So carpal tunnel syndrome is a good example there, or sensitivity. Upper limb as well here, potentially looking at some entrapment in the cubital tunnel, and how to assess that clinically. We also talk about how sometimes these things may not be appropriate, right? It's in the case of a patient is coming in with an acute injury diagnosis. They are telling you that they have pain. We're not going to go and test these things and see if we can recreate their pain for them. That's not the context here. But it would be, in a sense, confirmation of things that might inform our treatment plan. We go over spasticity assessment, both the modified Ashworth scale and the Tardieu scale. And then we do teach them a few bony alignment tests for the lower limb. So you can see on the screen here, femoral anteversion, Craig's-Reiter's test, or thigh foot angle. You can see an image of the Thomas test for iliopsoas and rectus femoris length. You can see an image of what's called Apley's scratch test, which is a commonly used orthopedic assessment for just general shoulder mobility, more of a comparison from side to side. And then Adams forward bending test for scoliosis. And I will say for some of our more specialized areas of assessment, our faculty kind of hit these areas as well within the core courses that they teach and go into a little bit more detail about that specific patient population. With scoliosis and cranial remolding being a prime example of that with Lisa and Megan. All right, so outcome measures are a part of the physical exam course, but we're not the only course that covers outcome measures at Baylor. Here, what we talk about is really going into the constructs of outcome measures, when you might choose a certain outcome measure based on a patient goal or your orthotic or prosthetic goal with your intervention. The differentiation between choosing a patient-reported or an examiner-assessed or a timed outcome measure and why you might choose to have one or both of those things, and then incorporating outcome measures into the physical exam flow. And we talk about some of the things that might impact this. You know, how is the clinic set up? Can you help in arranging an exam room or a clinic setup to facilitate the collection of outcome measures? Some clinics may have required outcome measures based upon certain types of interventions. So again, going over these, and the students at the end of their physical exam 2 course have to evaluate a patient model. They have to come up with a specific outcome measure that they would use given the findings of their evaluation and the patient's goals. They're also doing these outcome measures. I should offer that to the group as well. So when we have patient models here at Baylor on campus, for every single orthotic and prosthetic course that we have, they are doing outcome measures with their patient models as a part of that process. We're really trying to get them in the habit of that process from the beginning. All right, a few more slides before discussion. So I know well, I don't want to use the whole hour. Documentation does become a part of physical exam. Documentation is also a large part of our clinical practice management course, so that's taught elsewhere. But we do use the SOAP note format. There's a variety of acronyms that folks have used over the years to present the components of a SOAP note. We will ensure that the students are also including the addition of goals within that SOAP note, as well as patient education, depending on the context of that encounter. They're typically using a combination of a narrative and a chart table format for their notes. Because our residents usually typically get to experience at least 3 different electronic medical record systems in their residency, we actually don't have them go through an EHR system in the first year of the program. The approach is, if we can start to understand the important pieces of documentation and what needs to be in your note, and you're able to do it without some sort of kind of software guiding you and telling you where to click, we'd love to start there. And then what we hope is when you are interacting with the EMR systems, you're like, this is great. Like, this is a structure that's really helpful for me and I can move through this. And that's the feedback that we've heard from residents, but I'm happy to hear from anyone in the call. Talking to the students about avoiding the use of plus or minus, particularly in relation to range of motion, because that gets very confusing very quickly. In this, particularly in joints which move both directions in the sagittal plane, and avoiding the use of within normal limits or within functional limits, unless they're really saying, I only did just a visual inspection. I didn't get my goniometer out and measure, in which case that might be appropriate to use. All of our students at the end of the physical exam coursework create this, what I call a guiding document for them. And it goes through each type of orthotic or prosthetic intervention based on body segment. And it's their kind of cheat sheet list of, these are the important things that I need to do in physical exam. And for every single one of those things, they have to write a narrative of what that finding might mean for their decision making. So we talk a lot about, if you put something in that list and you can't tell me how that physical exam procedure impacts your clinical decisions, I'm going to ask you why you're doing it. So that's really, really important. Okay, some of these came up in our survey, and these come up with our students all the time. So teaching physical exam in a very controlled environment with usually their peers as the individuals on whom they're kind of training these procedures is not a representation of reality in clinic. And I think all of us know that. So some of the what ifs, right? Lisa actually just did a lecture this week with our students on pediatrics. Well, we can't do manual muscle testing with 5-year-old. The textbook tells me I shouldn't because they're too young. But there may be a condition in which we have an older child who really is not appropriate for manual muscle testing because of communication and understanding of instructions, et cetera. What are some functional substitutions that we could make? We go through kind of using functional activities with the patient in the exam room to make to infer strength. We wouldn't grade them, right? We wouldn't assign a 3 or 4 or 5, but we would kind of infer strength or weakness of a certain muscle group. What happens when my patient has limited mobility? Like, hey, Ashley, you've taught us I need to reposition the patient in a prone, side-lying, supine position to do all these texts by the textbook. But what happens when all I've got is my patient who's using a wheelchair and it's not safe for them to transfer? Let's talk about that. What do we need to do? So we talk about adapting to what you can do with a patient in a seated position, for example. And we talk about those clinical cheats. Like, okay, so you're going to assess knee flexion with the patient, strength with the patient in a seated position. Do that, but understand that there are limitations to that approach. So it might be helpful for you as the clinician to get a feel. Just acknowledge the limitations of that, right? We do teach the students some best practices in transferring an assisted gait. They learn how to do a variety of types of transfers. They learn how to use a gait belt, and we emphasize patient safety in this process. We also talk about, again, like limited mobility, space, or time. So understanding that with the constraints of clinic, there are going to be times where we might not be able to do everything that we think we should do in physical exam. So how are we going to prioritize what we really need in this process? That relates to bilateral assessment. So I really emphasize with the students and our faculty here do too as well, that we really need to take a look, particularly in the lower limb, of what's going on the contralateral side. Please don't think it doesn't matter for your intervention. We understand sometimes in clinic that might be on the chopping block in physical exam, but we try and get them in a habit of taking a look at both. Okay, from an assessment standpoint, what does this look like in class? How am I demonstrating that we are meeting these standards of accreditation? We typically start out with a multiple choice exam, and this is covering anatomy, procedures. We move from there into peer-to-peer work. So they use peer-to-peer practice for self-assessment, and then they actually use peer-to-peer in an exam context. So we're able to rotate through with a student taking the exam as the examiner, and then that student stays in the room and they now become the patient model for the next student who's coming in. We never ask students to pretend to have certain conditions. So this is just straight up procedural assessment and reporting. We move from there then, of course, to patient model. And this is typically a one-to-one faculty where the student is examining a patient model. Faculty is there in the room proctoring. They get a lot of practice with this in the first year of the program with all of the interactions that they're doing with our patient models. It's a little higher pressure though, right? Because they're typically doing those interactions in a group context. And they've got somebody to fall back on who might nudge them and say, hey, don't forget about this. Make sure you do that. And then all of this, of course, moves into residency, where you as the residency mentor might be there in the room saying, I'd love to see you do an evaluation for an AFO. Show me what that's like. In the residency portion of the program, we do a physical exam component as part of their mock board exams as well. Okay, I've talked for far long enough. As you guys know, the goal for the series was to just have a conversation about like, okay, here's what you're teaching. Here's what we're really doing. This aligns. That's fantastic. Maybe this is more. Maybe you don't need it. Would love to hear from you guys. So these are just some questions I put on the slide to potentially open up the floor for a conversation, but you don't have to answer these questions right now. But what I suggested was maybe offering what you wish new residents could do on day one in physical exam. If you feel like they're not doing what you'd like them to do, like what are you not seeing that you'd like to see? Or if you're a mentor on the call, what type of guidance do you find yourself providing to residents? Like, what are you saying over and over to new residents, and what would you like to see maybe addressed in school to address that? Last question for consideration would be, do you feel like preparation for or practice of patient evaluation in O&P has changed over time?
I think I would say I have not had a a resident, so this is kind of going back on my experience, but I think something that I relied on my preceptors a good amount for was how does physical exam transfer to order forms, right? We're
Mm.
shifting into a central fab, a technician based. Not often are we modifying our own things. So when I'm talking about a varus valgus post, what is the difference between 2 to 3 degrees, and what sort of information are we just selecting because it's common versus gathering from a physical exam of a patient specifically?
Yeah, Stacia, I appreciate that comment very much. And we were just doing work orders for KAFOs a week or so ago, and the way that the physical exam finding was presented on the work order was different than what they had done in class. And so that conversation came up of how do I bridge this gap between how I understand how I should present certain information, but how this work order is asking for it. So I think that's a really good point.
This statement goes back to your questions earlier on the little Quizlet. I think a lot of it is the students and the residents have the knowledge of how to do the exams. They just lack the confidence and being comfortable to start that conversation. So I think it's great to see that I've kind of coined it under the phrase the soft skill of communication, because so many of them enter this field excited about it, but they don't realize they got to go talk to live people and be able to get that history. And if they can't start that conversation, so I'm very excited to see that you have that as one of your modules of just going in and having that soft skilled conversation to get that history.
Yeah, Kevin, that's a great point. I can remember when I was in school for athletic training, like being so nervous about that conversation. And even just the fact of like, I'm going to go put my hands on another human to try and get information. It was just we're used to it now, but it's a weird feeling at first.
I think your hands on bring another point, especially when we got different genders in the room, whether it's male to female or female to male, especially when we start getting into the transfemoral range.
Yeah.
And it's like they've did an outside observation of how the socket or the diagnostic socket might be fitting, but it's like, have you really got your hands up in there and felt where all that anatomy is meeting up with your interface of that socket, rather than just guessing and then it all blows up and they come back for follow-up because you sent that diagnostic socket out for fabrication and they come back for that first follow-up. Like, oh, it is just eating me up in here.
Yeah, palpating the ischium is that's a great example of where we have some of those conversations. Yeah. Anything else? Mark?
Ashley, can I chime in?
Sure.
It's great. First, thank you for the presentation. I know with some of the residents that I have, I mean, one of the common things that they seem to be lacking is how to evaluate a leg length discrepancy, how to make up for it, how it would affect the sound side. It's a typical thing. They come in knowing what to do from muscle testing, but they always tend to lack that. The other thing is how to assess R1 and R2 values. I mean, I do a lot of children, so they don't know what to do with that either. So I think a little bit of work in that also would be well suited for them.
Yeah, absolutely. And we teach leg length discrepancy as functional and anatomical. So we teach them tape measure between umbilicus and medial malleolus versus ASIS and medial malleolus. And then I agree with you. So I will say we teach the Tardieu scale for R1 and R2. We teach modified Ashworth, but that's definitely an area where if learning those assessments on someone who doesn't have spasticity is like not even really helpful. And so that's definitely an area where once they get out into practice and they're working with patients who have spasticity, they really do need to hone in on that. I agree.
So, hi, this is Kevin Felton from Scottish Rite Children. I've got two things. One, I have not seen this with Baylor residents, so maybe you're doing a better job. But I've had residents just grab a patient's leg. Like, wait, no, you need to explain what you're doing and not just grab somebody. You can get away with it in pediatrics oftentimes, but that's been one of the things I've really struggled with in a few cases. But the other is, you were talking a lot about manual muscle testing, and I don't have the strength to determine a lower extremity muscle between a level 4 and a 5. A teenage boy's leg is stronger than my arms. I just can't do it. And so I'll have a resident say, oh, this is a 5. And it's like, well, have a patient hop. Oh, you can't hop. Well, that's obviously not a 5. So, where do you make that difference between manual muscle testing and functional strength testing?
Yeah, no, Kevin, I think that's a great point. And where manual muscle testing lacks is, as you've alluded to, is the subjectivity of that person applying the resistance. And if you haven't really paid attention to that over time, you can lose that, right? Where you think it's full strength and then functionally that's not true. Yeah, I've actually seen research where folks have looked at, it was physical therapists that work with the geriatric patient population, and they actually had them come in and do manual muscle testing. And all those physical therapists who were working with that population were applying less force for a grade 5 than the physical therapists who were working with athletes. So we are like unconsciously modifying the amount of resistance we're applying based on our patient population. It's almost like you have to think about that. Yeah, it's a good point.
To kind of add on to that, Ashley, I think it's important to also recognize when manual muscle tests are appropriate and when like more functional type tasks are appropriate, like in the case of neurologic patients, for example, where volitional control might be different than how they present during gait, for example.
Yeah, Emily, that's a great point, and one that I think is challenging to communicate to students without that. We've had a few patient models where that's been a good topic of conversation of like, I did MMT and I found this, but then when I watched them walk, I saw this, and it's not lining up what's going on. Yeah.
Yeah.
Yeah, Ashley, this is Carl Barner from Children's Healthcare of Atlanta.
Hi, Carl.
Hey there. Do you have discussions with the students about how the muscles function in open and closed kinetic chains? Especially like in the gait, like a quad, you sit them down and they extend their knee and you grade them. But the quad main function in gait is shock absorber. Yeah, exactly.
Yeah, so we do that, I would say, and I think Sally hopped in the call. I think they get the majority of that conversation within the biomechanics course that Sally teaches. But this point is a really, really good one. This actually came up at the Academy meeting, post-session conversations where someone said, hey, manual muscle testing is an isometric or a concentric assessment. And functionally in the lower limb, I'm most concerned about those muscles functioning in an eccentric capacity in their strength. So how do I reconcile these? I think some of you on the call have alluded to this, right? Like revisiting functional assessment. It's a great comment. And there are some of those tests out there. I haven't seen them done in the context of P&O, but there are certainly validated functional movement screens that we could be using. Oh, I might have missed something in the chat. Hang on a second. Oh, someone asking for the physical exam chart for prosthetics and orthotics. I would love to. I would actually love for something like that to move into something that's published and available, you know, after it goes through a bit of a consensus process in the lit review. But yeah. Wonderful. Well, I very much appreciate you guys engaging and sharing what you're seeing in clinic and where we could be bridging the gap. I think that's really, really important. You know, as educators, we love the fact that we can have this type of a conversation. Our goal is to best prepare our students to step into residency. And we can't do that without hearing from you guys. So I really appreciate it. And happy to open the floor to anything else, but also recognize it's the end of the lunch hour. And I appreciate you all and your time.